Well, hi everybody. My name is Garrett Schmidt. I'm the managing editor for VBC Exhibit Hall. Thank you so much for joining us today for today's live webinar hosted by Roji Health Intelligence. And I'm very excited about the topic today. It is called Customize Your APP Approach, how a low-cost solution today can drive innovation tomorrow. So pretty straightforward. And actually, this is what we're going to talk about today. So very excited to hear from our speaker. A few items of note before we begin. Everybody has joined today in listen-only mode, so this is a traditional webinar format. You don't need to worry about muting your microphone or turning off your camera or anything. Don't worry, we can't see you or hear you. However, we will have a time for some Q&A towards the end, so we do want to hear from you. So if you have a question at any point during the webinar, go ahead and put it into your control module. There's a place specifically for questions. And we're going to get to as many of those as we can during the allotted time. If we don't get to yours for some reason, we'll make sure to reach out via email afterwards to make sure we get your question answered. Also, today, the session is being recorded. So afterwards, what's going to happen is you'll receive an email from one of our staff, and it will have a link to the recording as well as where you can download the slides from today's session. And you'll want to do that because there's some good information there. And finally, without further ado, I want to introduce our speaker today. We have Mr. Dave Halpert, and he is Chief of Client Team with Roji Health Intelligence. Welcome, Dave.
Thank you, Garrett. Good to be back. All right. Well, good morning, good afternoon, I suppose, depending on where you're located. Thanks for joining me today. As Garrett said, we're going to be talking about how to customize your APP approach so that a low-cost solution today can drive innovation tomorrow. And so the presentation is for health systems, medical organizations participating in, or actually participating in an ACO, most notably board members, hospital and medical organization administrators, compliance officers, and also for information technology specialists. This is going to be important for you as well. Give you a basic track of what we're going to be discussing today. First, how the APP differs from the CMS web interface, the requirements to successfully report via the APP, the benefits and the pitfalls of each of the reporting options. There are several different options that you can select, and we'll talk about which one is the right one for you, how to prepare, and how to make most of your resources, what to expect from your partner, your qualified registry, and then finally, those 10 metrics for data-driven quality reporting. So before we get too far into the weeds here, let's do a quick polling question. Which of these best describes your APM performance pathway strategy? Option A, I will report through the CMS web interface for as long as I can. Option B, I want to get an early start so I'm ahead of the curve, but I really don't know where to start. Option C, our APP strategy is in place and we know the type of measures that we're going to report. And option D, I do not know what the APP is, but I am told that I am in charge of our strategy, so please send help. I'll give you a couple of minutes to answer that.
All right, great. Yeah, when we've got the poll is up on your screen, should be. So go ahead and select an answer. For those of you who are just joining, and we do have a number of people that are coming on now. We're doing an audience polling question, and it is which of these best describes your APM performance pathway strategy. And this is a choose one. So go ahead and just select one that best applies, and then we will show the results here soon. And of course, this is anonymous, so your answers won't be shared with others, but you can get a chance to see where you kind of stack them among your colleagues. So let me give it just another 30, about, I don't know, 10 seconds or so, and then we'll close it down. Okay, and I think most of the answers have come in at this point, so I'm going to give it about 5 seconds and then we'll go ahead and close it down. Again, for those of you who just are joining, we're doing an audience polling question. All right, 5, 4, 3, 2, and 1. And so I'm going to close it down and share the results. All right, Dave, are you able to see the results?
I cannot. Can you read them to me?
I sure can.
Thank you.
So we've got I will report through CMS web interface for as long as I can is 29%. We have I want to get an early start so that I'm ahead of the curve is at 43%. Our APP strategy is in place and we know which type of measures is 29%. And we don't have any for the I don't know what APP is. So that's a good sign.
That is a good sign.
Don't
All
be
right.
discouraged if
Well,
that is you, because
all
we're
right.
going to cover a lot of ground here.
Absolutely. All right. Well, that's very great to hear. So before we get into that, tell you briefly about us. Roji Health Intelligence provides value-based care technology and services to improve outcomes, cost performance, and to improve equitable healthcare. And we try to identify, well, we don't try, we do identify patients with persistently poor control or high risk outcomes and target specific health interventions for them. So it's not just a question of looking up a value, it's something that gives you something much more actionable. And so we're able to engage our clients, physicians, and clinicians on improvement that actually is visible and measurable for patients. So, what is the APP? It sounds like everybody knows this already, but it is a quality reporting method for alternate payment models. APMs are risk-based reimbursement models, much like ACOs. APM performance pathway is APP. And so, obviously, since it is Medicare, we've got that fun abbreviation within an abbreviation, and that's how we get it. The purpose of the APP is to ensure that quality is measured for all patients eventually, because we saw some changes in that final rule for 2024 that opened the door for a new type of reporting. So why is CMS trying to transition to the APP? Well, the first reason is because it aligns with the merit-based incentive payment system, MIPS. Having those measures scored the same way for each type of organ or each type of track in the quality payment program makes measurement more consistent. It's the same measures being used, and if people are being measured the same way, it is easier then when those results are posted to the CMS public reporting site. It ensures that patients like you and me are able to make an effective determination on quality. And then finally, it includes a greater proportion of the population, and therefore it's more accurately going to measure performance. The larger your sample, the more you can determine from that type of measurement. And this is a whole new ball game. And the reason I'll say that is because that CMS web interface, we're talking a sample of 248 people, and this goes far beyond that. And so the first thing that is the big change is that there are fewer active measures that you need to report in the APP. So instead of all of the measures in the web interface, you only need to actively report on 3 measures. And the first one is diabetes, hemoglobin A1C control. The next is the preventive care and screening, depression screen and follow-up measure. And then for patients with hypertension, controlling high blood pressure measure. These are all in the web interface now, but they're reported slightly differently in the APP, and we'll talk about how that is in just a moment. In addition to those measures, there are some measures that are calculated directly by CMS and from survey vendors. So there's the CAPS Patient Experience Survey, the hospital-wide 30-day all-cause unplanned readmission rate, and then finally the risk standard admissions for patients with chronic conditions. And so the 6 of these will create your quality score in the APP. There are 3 options to report those same measures: the A1C control, the screening for depression and follow-up, and the blood pressure. So even though they are the same measures, they are reported 3 different ways. CMS refers to them as collection types. The first is electronic clinical quality measures, and these are the ones that come directly from the EHR. The next is MIPS clinical quality measures, which are similar. And then finally, the new one for 2024, Medicare clinical quality measures, or Medicare CQMs. So, how do they compare? Well, the Medicare CQMs are for traditional Medicare patients only. So it's still going to be a greater population than you're seeing for the web interface because it's not just a sample of 248, it is all traditional Medicare patients. Um, and then MIPS CQMs and ECQMs are for all patients. The MIPS CQMs and Medicare CQMs allow for manual intervention, meaning that it's not something that is generated directly from the EHR and completely hands off. There are opportunities to manually input values. There are opportunities to create customized data types that allow you to report, and then ECQMs do not. It's whatever is stored in those spots in the EHR will automatically run through. Finally, the denominator calculation. CMS calculates the denominator for Medicare CQMs, and for the MIPS CQMs and ECQMs, that denominator is calculated by a qualified third-party intermediary. So it could be an EHR, qualified registry, or a clinical data registry. So let's get back to the all patients in the MIPS CQMs and the ECQMs for a moment. It is not hyperbole. And so when we say all patients, we are talking about whether they are on public insurance, private insurance, or are paying completely out of pocket. They are still a part of that quality reporting denominator. And so that means that instead of 248 instances per measure, like the web interface, we are talking about question mark, question mark. And for some of those large ACOs, obviously the denominator could be enormous. And so the other thing that is important to remember here is that these measures require data aggregation from each EHR, as the results that are required to report for the APP are the most recent values for each patient. So a unique patient record at the ACO level is required. Now, that was obviously enough to scare a lot of people. And so Medicare introduced for 2024 what they refer to as Medicare CQMs. They're a stepping stone where you are going to be reporting a much larger set of patients than before. You're going to be submitting the results in a different way than before, but it is limited in that it's only traditional Medicare. And the way the process works is that CMS is going to, in addition to the quarterly uploads of claims data, they are going to send out a list of patients who have triggered these measured denominators based on their visits with clinicians who are involved in the attribution aspect of the ACO. And so you'll know who they are. You don't need to, in small ACOs, necessarily have a full data aggregation strategy yet. For larger ACOs, patient numbers are going to be much too large to manually abstract numerators. In other words, there are going to be too many patients for nurses, clinicians, any sort of chart reviewers to track all of these people down to find them. But a vendor who can customize a targeted data aggregation approach is an effective solution for APP reporting. We'll talk a little more about what that means, but the short version is that ACOs are going to be able to, even without a full data aggregation strategy, be able to be successful in APP reporting with the right vendor. There are a couple of concerns with the Medicare CQMs. The first is that since these lists are delivered with CMS's quarterly uploads, that final list is not going to arrive until mid-February or so. And since the submission period begins on January the 1st and ends on March 31st, not having that final data set to know who is under measurement is going to really put you in crunch time for those last 6 weeks of the submission period. So the other thing to consider is that yes, it is more cost effective as it relates to your data aggregation strategy, but it is going to be less comprehensive. There's going to be less that you can do with it overall. And then in the very last bit, The data is submitted to CMS via qualified third-party intermediary, like a qualified registry. So it's not something where you're sending the data on your own. It's something that's being pushed through by a vendor. So we know that the CMS web interface is going to sunset in 2025, but really your transition should start now, and that is directed at those 29% of you who really want to keep going. I'm going to do my best to give you the reasons that you should think about the APP in 2024. I'm going to guess that your reasons for sticking with the web interface are related to what we refer to in-house as some of these big fears. There are too many patients to manually compile numerator values for measures. That 248 sample size it's challenging to get through on its own, and so the idea of growing that exponentially is a little bit scary. There's also the fear that it's going to be too expensive or problematic to aggregate data to report on all patients. These are going to come with administrative burdens for providers and staff. And then finally, there are going to obviously be some performance implications for ACOs with underserved populations. There aren't going to be the same types of access to care as others. And so things like hemoglobin A1C and blood pressure values are very likely to be affected by that. So to mitigate some of those, CMS has developed some incentives for starting early in the APP. The first is that there is a health equity adjustment for ACOs with underserved populations, and it's up to 10 quality points based on the rates of dual eligible status, and then also by measuring the rates of patients in specific area deprivation, or based on area deprivation index rates for your population. The other thing that CMS has done, which is going to be useful, is they've created a sliding scale for quality performance. So when you report through the web interface, it is all or nothing. If you do not meet that performance standard, you are automatically excluded from any type of eligibility for shared savings. When you report through the APP, that is not the case. If you come close, there is still the ability to share in some savings. There is actually a sliding scale. So there is the ability to share in savings even if you do not perform as well. In addition to those incentives, there are also eased performance standards in 2024. So for the APP, you are required to report on 75% of the eligible denominator for 3 measures. And for one of your outcome measures, you only need to hit the 10th percentile of the performance benchmark, and you can still meet the performance standard. The others need to meet the 40th percentile. Whereas for the web interface, you need to meet the 40th percentile all around, and if you don't, you are completely out. There is no opportunity to share in savings. So yes, there are fewer patients. There are more measures to report, though, so those two things do balance out a little bit more. So what we need to talk to now is a step-by-step path to APP reporting success. The first thing that you need to do for your forward-looking APP strategy is get the expertise and the infrastructure you need to report. This is something that you're not going to be able to do on your own, and you need to find the right partner. Then you need to choose your reporting method, whether it's going to be the MIPS CQMs, the eCQMs, or the Medicare CQMs. Then you're going to need to take a look at your practices, identify all of the data sources in your ACO, look at their export capabilities. What are they able to provide, and how is that going to affect your ability to report? And then finally, capitalize on your investment. The first 3, they seem to all be very focused on quality reporting, but that's only the first step. The next piece is what can you do on a larger scale, going to affect the cost side of things and improve both the quality of life and the health of your patients. So let's talk about that first one. Expertise comes from experience. You need someone who is ONC certified because you're going to be dealing with both electronic clinical quality measures, and in addition to some of the others. You want someone who has experience doing quality reporting. So Medicare opened up the door for qualified, they called them at that time qualified registries only, but they opened the door for these third-party intermediaries to report data on practices and clinicians' behalf to CMS back in 2008. So how long has your partner been doing that? Has it been all the way back to 2008? Have there been any probationary incidents with your partner? So these are the kind of questions that you need to be asking. Do they have experience aggregating data from different EHRs? A patient-centric database is a must-have. So even before qualified registries were allowed to report data on behalf of clinicians to CMS, there are people out there like us who have been doing this for 20 years now, helping people avoid running afoul of the Federal Trade Commission in the pre-ACO days when people were still clinically integrating. To do that, that means being able to match patients across practices, even when there are disparate EHRs. Nobody's going to share a medical record number. And then finally, being able to create analytics on cost and quality. So it's one thing to be able to match these patients from disparate sources. It's quite another to be able to show you the information that you need that is actionable so that you can improve. One thing that we have learned in our time is that experience must include customization. No two organizations are identical. There are going to be at each group varying populations, priorities within the organizations. There are some things where the organization is going to be looking at very different goals, long-term, short-term, than others. And then finally, technical resources. So yes, the cookie cutter approach does look great on paper. Everybody wants it right out of the box, but experience sees cost-effective solutions that perform in the real world. So it may look great, that out of the box sounds wonderful, but unless it actually works for you, it's not going to get you anywhere. So the next thing you need to do is to select the correct APP reporting option for your organization. Medicare CQMs have a limited population, but and the denominator is slow to update. For larger ACOs, populating those numerators is going to be a big issue. So Medicare CQMs may not be the greatest option for you. MIPS CQMs offer flexibility and safety nets in terms of the way that data can be collected, but they may require additional effort. ECQMs are automated but carry all kinds of risks, and there is no guarantee that all of the EHRs within your ACO are able to produce the right sorts of files that are needed. And if you can't do it for everyone, you can't do it at all because there is no manual intervention allowed. So when should you use Medicare CQRMs? A stretched budget, that is the first thing. Our costs are less than 30% of what they are for a full data aggregation initiative when we're looking at a Medicare CQM approach. There's also a good case to be made when there are too many EHR unknowns. If you are in a large system and you are maintaining a lot of EHRs with uncertain capabilities, Medicare CQMs could be a good first step for you, at least until those some of those unknowns are addressed in terms of what sorts of files they can send, what practices are even using. Do you still have a few that are on paper where they're billing electronically, but their clinicians are still using paper charts to record all of that clinical information? Limited staffing. If you're able to identify and address trends of the traditional Medicare population, okay, that is still going to be a greater benefit than looking at those 248 patients per measure. And so if you do not have a lot of staff to dedicate to this, this is a good jumping off point. And then finally, a short timeline. It is much quicker to begin with Medicare CQMs because the data aggregation process is more superficial. So those are all great reasons to utilize Medicare CQMs. Those all patient measures do require data aggregation. So an advanced clinical data registry can offer data aggregation options, like my picture on the right here, taking different sorts of data and being able to take that information about the patient, matching it down, and being able to, in the end, create a unique patient record where they're matched across disparate data sources. These options, there are a lot of options that are significantly less expensive than QRDA files, or especially setting up interfaces. You will be pleasantly surprised. There's also interfaces for direct entry in those emergency situations where the information is in the record, but it is not something that can be exported out into data, but you have it. It can be exported here. It gets you APP reporting ready, plus you do have some patient-centric insights. All right, so the question is MIPS CQMs or ECQMs. So if we're looking at reporting for all patients, this is where we want to determine whether or not we want to do it directly from our EHR, or if we want to use MIPS CQMs. When I say directly from our EHR, I mean they're both going to come from EHRs, but the ECQMs, remember, are hands-off. It is whatever the EHR says, and that is the end of it. Background work is critical. Surprises equal delays. So you really need to know a few things about your systems in the ACO. Obviously, the basics, name, version, especially ONC certification status. If the EHR is not ONC certified to the most recent Cures edition, then that ACO is not going to be able to report the information that you need. You need to understand how they are connected to other entities around. Are there commercial lab interfaces? Is there a link up with other hospitals in the area? Is there an HIE? These are all things that can enhance the ability of data that you're able to create. But for some of them, it will mean that to use that data, you need to use MIPS CQMs versus ECQMs. Workflow, this is a good one because those ECQMs are based on how that EHR scoops up the information and reports it out. So in some cases, custom templates that have been created may alter that process. So your physicians may be documenting excellent results, but if they are not stored in the location that your EHR is retrieving them, then you are not going to get credit for them. And then finally, who do you contact with regards to the EHR? Is there an IT staff person? Is it the organization directly? Where do you go in case of troubles? And if you want to learn a little more about this, please follow the link below when these slides are sent out. We've got a great section here on tips that will help you prepare for data aggregation. One thing that I wanted to flag here is that even if your all of the EHRs in your system are able to produce a QRDA file of one type, and QRDA, I should specify, stands for Quality Reporting Document Architecture. It's how it's a file type for reporting quality measures. You cannot add them together. Adding QRDA3 files isn't a solution because those are aggregate reports. There's no patient level detail, and you need the most recent result. Likewise, you can't also just add your results from the quality reporting document architecture one file, the patient level detail, because it's not aggregated. So let's take an example patient here, our patient John Doe. They have an A1C at practice 1 with EHR1 in January, and then they have another A1C taken at practice 2 using a disparate EHR. For each of those practices, those EHRs are going to be recording that John Doe was eligible and whether or not performance was met or not based on the value. But when you're reporting this information to CMS, they want the most recent value only for each unique patient. So it should be a question of what is John Doe's most recent A1C. But if you simply add the two together, you've counted John twice. You've created an invalid denominator and a corresponding invalid numerator. So when should you utilize MIPS-CQMs then? First of all, if there is variable documentation method between practices and providers, you're going to need several approaches. This can be whether you have a single EHR or whether you have multiple EHRs, but particularly when you have a single EHR, if you have people documenting in different ways, there is going to be an issue down the line in where the scores are retrieved and how they are delivered. You should also think about MIPS-CQMs if your EHRs can't all generate QRDA1 files. So advanced clinical data registries can aggregate QRDA1 files. Like I said, you can't simply add them together, but if you're able to match patients between those and create the unique record, sure, you can use them. But if your EHRs can only produce a QRDA3, that automatically eliminates you from ECQM contention because it's not something where you can tie the score down to a unique patient. The last reason, and probably the most important reason to utilize MIPS-CQMs, is a desire to support additional metrics for quality efforts. There are a lot more MIPS-CQMs than ECQMs, and also one of the things that Medicare has floated is that potentially for ACOs with specialists, those specialists who report in addition to these ACO measures, the a MIPS value pathways set. So these are measures for MIPS that are centered around either a specific condition or a procedure. Those ACOs may be eligible for bonus points in the quality area. That's something that Medicare is looking at down the road as a way to bring specialists into the fold. And so with MIPS CQMs, you are going to be able to support that much more easily. You'll want to use ECQMs when quality reporting numerator and denominator collection process are in sync with real world workflows. If you have a process that creates all of this information, great. That's a wonderful thing to have. Provider education on documentation is comprehensive, and there is provider buy-in. That last piece is critical because if there is not provider buy-in, sure, you're going to start, find the first month, maybe find the second month, but it is going to dwindle. People are going to fall back into old habits, and you are going to see results that don't necessarily reflect reality because documentation has gone back to the manner in which you had tried to avoid. The other reason you'd want to look at ECQMs is if all EHRs can meet ONC standards and can readily produce QRDA1 files. So every ACO is unique, and the trick is to find your sweet spot. So you want to look at things like your EHR setup. Are there variable EHRs? Do you have a single EHR? One of the most important things, though, to consider is your value-based care strategy as a whole, though. If you're looking at something like either ECQMs or Medicare CQMs, your value-based care strategy is going to be limited to the measures in the APP, those three reporting measures. And so, yes, they're obviously valuable, but you have a real limit on how far this can take your overall value-based care strategy. And if there's anything that we have all learned in these last couple years, it is that resources are scarce and having things siloed is not efficient. One thing to flag before I move on to the next slide is that those Medicare CQMs and the MIPS CQMs do allow customized data solutions. So it is not necessarily based on what your EHR says the results are. There is the ability to compile different sets of data and to process those so that you can succeed in either the MIPS CQM or Medicare CQM reporting fashion. So the bottom line is you can do more with all patient measures. You want to be able to leverage data aggregations to improve outcomes in other areas. You don't just want to focus on these three quality measures because that is not an efficient use of your time, your clinician's time, your ACO's time. You also want to be able to look at measures for other specialties, like I said, the MIPS value pathways. However, with that said, getting into the APP now is good because of those incentives that CMS has outlined, and you can start to move the ball forward with data aggregation. And of course, you are going to have a larger population for which you are able to look at results, identify trends than you would with a 248 patient sample. Now to the last part. Once you have created this investment in your quality reporting, you can use it to create new opportunities here. So we've got Wrigley Field already. Wouldn't it be great if we could also get Springsteen there? So quality reporting is the entry level benefit to data aggregation. You've done the heavy lifting already, and you need to be able to improve. You want to capitalize on that investment. Start with the quality measures. This is what you've already gone and done, and so you are able to start here. If you see a performance shortfall, you see your patients have poorly controlled A1Cs, or they have high blood pressures, or the screening for depression are not where you want them to be, you can start asking questions. So for patients with high hemoglobin A1Cs, are there treatment plans for changing this? Have there been any updates to medications? Um, Blood pressures, are they really high or are they being taken improperly? We had a client who we showed some analytics to showing which providers had populations with higher average blood pressures than others, and the client realized immediately that this was the group that had hired more nurses recently, and they had not been educated on the proper methodology for which to take a blood pressure. So things like back supported, both feet on the floor, don't talk to the patient. They hadn't been instructed there, and so they had high blood pressures. But if you are going after the providers or the clinic to lower blood pressure, where is the change really coming from? And then the other thing we have seen is that depression screenings or lack thereof have oftentimes resulted from a lack of available in-network mental health care. So these are all questions that you're going to need to be able to identify when you're looking at improvement down the road. You can't just say get better. You need to understand why they have fallen in the first place. And so that's what we're looking at here. We're looking at an application on population health where you can see this group of patients who has persistent poor control of diabetes and is obese, is only on insulin. There aren't other medications that are in here, and so you're able to track outcomes over time. Are you getting better? Are you getting worse? Because if you are getting worse or if you're staying stagnant, that may be a reason for needing to update your approach. Once that's completed, you can graduate to advanced topics. So you can identify patients with persistently poorly controlled intermediate outcomes. These are the patients who are going to be more likely to receive inpatient or emergency care. And so you are going to be more likely to intervene. And this is where you're going to see greater effects on shared savings when you're not having the same number of inpatient services, you're not having the same number of emergency department uses. So it's kind of a multiplier effect. As your patients' outcomes improve, your cost scores are going to improve as well, as are your quality scores. And again, most importantly, your patients' quality of life. They're going to be healthier and happier people. You can start to look at whether there is variation between sites, providers, and branch out even further. So when you aggregate data for all patients, you're able to see where you can target populations. So in this graphic here, we can see we've got a persistently poor controlled group of patients with diabetes. Yes, their A1C is high, but that's not the place. That's not going to be actionable for you. You want to be able to see whether they have a behavioral health diagnosis in addition with no behavioral health visit, or you want to know if they have been referred to a nutritionist and haven't gone, or if there are social determinants of health indicators. So the more data you have, the more you're going to be able to branch out. You're going to be able to see whether episodic costs for procedures, not just chronic conditions. You're going to be able to see whether there is any difference in procedures. You can see the root causes of persistent poor control. That's in the slide that I showed you previously. Understand your patient's social determinants of health needs, because this is going to be critical the more people you have in your quality reporting profile. And finally, the ultimate goal, to demonstrate a single high standard of care by engaging private health plans in your value-based care initiatives. You don't want to have one group of patients that gets a certain type of concierge treatment and then everybody else. This is something where you want to have the best care for all patients. Here's what a graphic looks like for comparing intermediate outcomes by provider and site. This one here is looking at diabetes and the number of services by type and the cost per type for each of these providers. Does this necessarily mean that one provider is worse than the others because the costs are higher? No, it doesn't mean that at all. There may be different populations that are in play, but you can't get to the actual issues here until you are able to ask the right questions. And this may mean that, yes, a person has a much more challenging population, and that the ACO's resources are best served helping some of the people who need it most, compared to the same sort of distribution of resources to all. You can do the same thing with the procedural costs. So if we're looking at cholecystectomies, you can see which providers have higher costs than the others, and also the ones, this is something that we've developed, who have a greater rate of what we're calling notable observations. These are not necessarily mistakes. These aren't, we're not saying that one provider is better or worse than the other, but it does give you an idea to start asking questions and where those questions may be directed. We've had clients where one provider's costs and infection rates were consistently higher than his peers because he was continuing to perform open cholecystectomies rather than laparoscopically, and the only reason was because, well, this is how I've always done them. And it's illuminating things like that that can really drive costs down. And so here we are at the end of our journey here, the 10 metrics that you really should be tracking for a data-driven quality approach for value-based care. First and foremost, you need to be able to longitudinally track clinical outcomes. Is that improving? You need to be able to identify cost and outcome variations for conditions and procedures and practices. You need to be collecting social determinants of health data from either using ICD-10 procedure, or excuse me, ICD-10 codes, or through natural language processing. If you aren't using the ICD-10 codes for social determinants of health, I would strongly advise that. They're very important in terms of being able to identify which patients need the most support, and then also they are used for risk adjustment and from CMS. Increased screening for chronic conditions and potential events. Obviously, if you are screening for patients with hypertension, you are screening for diabetes. The best thing that you're going to be able to do is catch that early so that you are able to maintain control. You don't want to find out that you have diabetes at the emergency room because of a catastrophic event. Should be measuring the change in providers who are interested in practice transformation and whether or not there is buy-in to the APP. Measure whether there is a presence of defined outcomes for future improvement. Are we saying that we want to get better, or are we identifying the actual things that we're going to be using for measuring whether or not we're going to get better? You want to be able to measure the increase in implementation of interventions for patients with persistent poor control. Are more of our providers doing these than before? It's wonderful to have them, but you should be measuring whether or not the providers are engaging with them. Improved and measurable experiences for patients and caregivers. And finally, demonstrable improvement over time. Are we getting better in the metrics that we have identified? And that brings us to our questions and answers.
Okay. Well, we do have some questions that came in, and Dave, thank you. This is there's a lot to this. Obviously, there's a lot here, and so if you have a question that you'd like to ask our speaker, go ahead and submit that now, and we'll get to as many as we can using your little control module there. So, in no particular order, let's start with this one. How does reporting work if we switch EHR mid-year?
Oh, great question. And it's not the answer that a lot of people are hoping for. You do not get any dispensation with CMS if you switch. So you're not allowed to, like I said in that slide, add the results between the two EHRs. There does need to be an aggregation of the data in those EHRs so that you are able to see, for example, patient John Doe in System 1 in February is or is not the same John Doe in System 2 in October. They need to be aggregated together with one comprehensive patient level submission.
Okay, great. All right, next question, moving right along here is how long will we be able to use Medicare CQMs?
CMS has not defined that. They put language in the final rule that they are out there for the time being, but they are not intended to be a long-term solution. So what that should signify is that yes, they are a stepping stone, but they are going to be a temporary stepping stone. It should not be the approach that you take for a long-term strategy. They should be your jumping off point, but the goal should be to move on from them because they could conceivably go next year.
Mm-hmm. Great. All right, next question here is do all patient measures earn higher incentives?
No, they don't. They like I said, Medicare is trying to really make this a stepping stone for people to get into the eventual all patient reporting. But for 2024, it is the use of the APP in general that earns the incentives, and not without regard to the data collection type.
I see. Okay. Um, Next question here is do you expect that in the next few years, CMS will require more than the three measures now required? And if so, when and what?
Absolutely.
Can you see
I
the
don't.
future, Dave?
Yes, absolutely. Looking into my crystal ball,
Okay.
I would expect that CMS is going to look at additional measures to report. They are going to be largely outcome based. Of that, I am certain. Either outcome based or patient experience measures. That's been their
Mhm.
very specific move. And what will change also is that CMS is wanting to get into what they're referring to as digital quality measures, DQMs. And the distinction between ECQMs and DQMs and MIPCQMs is the DQMs are going to be kind of a marriage of ECQMs and MIPCQMs in that there are going to be different types of data that flow into each, and there's going to be different vendors that are involved to make it work. And so that's when we're starting to look at things like patient wearable technology and measures tied with all sorts of things like that that we can see. But yes, there are going to be more measures because they're also going to want to cover additional conditions as well. You can see that just in the last few postings that CMS has made. increases to the kidney care choices model. So obviously, kidney health is very important for them. There's a sickle cell initiative that's just been brought up in these last couple days. So I think it's fair to say that more measures are coming down the road. And in terms of when that will be, the best thing that you can do is to read those proposed rules and comment on them. They come out in generally July-ish, uh, to make your opinion known.
Yeah, and I believe there's some CMS interactive calls that you can participate in as well to kind of keep tabs on what's coming out and hopefully uh, gauge what changes are coming from there at least a little bit better than kind of going into it blind. So I encourage you to look into that. But that is the last question that we had, Dave. I want to thank you again for this topic. Again, folks, there's a lot here. I know this is a weedy subject, but Roji Health is a very capable, very knowledgeable organization. You're in good hands if you want to know more about this and your positioning therein. I wanted to encourage you as we close out here to stop by the virtual exhibit hall booth at vbcexhibithall.com, where you can check out the Roji exhibit booth there. And it's kind of like a living, breathing um, brochure of all the things that they're doing in the value-based care space. You can read up on what they're doing and their resources, and there's just a lot of great material here, as well as a whole library archive of articles that Terry and Dave have both written, and a lot of great material here. And then finally, if you'd like to reach out to Dave or to the Roji team, feel free to do so. Leonard's information is here, and he's the contact guy, but Dave's is also here as well. So feel free to reach out to either of them, or I'm happy also to facilitate an introduction if you would like. So you can reach out to me as well. But I wanted to thank you all again so much for coming today, spending your afternoon with us. I know there's a lot vying for your attention right now, so I appreciate your time. And again, if we can do anything to help you or answer any questions you have, feel free to reach out. Have a wonderful rest of your day. Thank you so much.
Thank
Bye
you.
bye.
Bye bye.